Hi everyone, I'm Dr. Sandeep Sharma, your Pediatrics Super Specialty faculty at PrepLadder, and I welcome you to this INI Super Specialty type MCQ. If you have appeared in the exam previously or if you have practiced the past questions, you would know that disorders of sexual development as well as CAH are high-yielding topics. Today I'm going to discuss a topic, an MCQ, not a topic but an MCQ, which is very similar to a past question. This question discussion will also tell you an important concept regarding the therapy, and I will also share the pitfalls that students make that you should avoid in future similar MCQs. So let us first have a look at the question. So the question says there is a 3-week-old female neonate who presented with hypoglycemia. So in a patient where disorders of sexual differentiation are being discussed or CAH patient, the gender is very important. So if the examiner says female like gender, then we are not sure. But if the examiner says female or male, then you have to be clear that the genotype of the patient is what is mentioned here. So if they say 3-week-old female, we have to assume that it is a XX genotype which is being talked about, right? So let's see what the examiner says. 3-week-old female neonate presented with hypoglycemia, reduced urine output. She is having poor pulses, raised CRT, capillary refill time is raised, sodium is on the lower side, potassium is on the higher side, and there is also evidence of ambiguous genitalia in the form of clitoral hypertrophy and fusion of the labioscrotal folds. And they have given one parameter that workup revealed elevated 17-hydroxyprogesterone. So likely CAH, she was started on hydrocortisone at this dose. Right or wrong, we don't know, we have to see. And there was inadequate response to this dose, so the dose was hiked. What is true regarding fludrocortisone as add-on therapy? Fludrocortisone is a synthetic mineralocorticoid, and what is its role in this patient? Let's have a look at the options. Option A, fludrocortisone is started at dose 0.1 mg per kg per day. Option number B, fludrocortisone not needed at high dose of hydrocortisone. Option number C, fludrocortisone is avoided in female CAH patient. And option number D, initial dose of hydrocortisone should be low so that you can add fludrocortisone initially. Now, all the options look to be correct. In fact, the brief version of this question was asked some years back, and many students were of the opinion that A is the answer, some said B is the answer, C everyone knew is not likely, and D again it was marked by some of them. So let us first evaluate. Actual exam you will not have so much of time, but if you get a similar question, how you are going to approach such type of MCQs for super specialty, that is what I am going to discuss here. So let us put it in a smaller box and focus on the information given to us. So what we are seeing here is, it is a neonate, right? So a child presenting in 3 weeks of life. Generally we know that congenital adrenal hyperplasia patients do not present at birth, they present between 5 to 7 days of life till about day 28. So generally second or third week of life they will be presenting. So it is a female neonate who has presented. What are the features she has presented with? She has low blood glucose, so hypoglycemia is there. She has low serum sodium, so hyponatremia is there, and she has increased potassium levels, so hyperkalemia is there. Plus, along with these two, she is also having a reduced urine output, she is having raised CRT, and she is having poor pulses. What this basically means is that there is mineralocorticoid involvement in the form of hypoglycemia, and this shows that she is having a salt wasting crisis. Now often these children present with salt wasting crisis. Salt wasting crisis means there is an absolute or relative deficiency of mineralocorticoids. Due to this, there will be hyponatremia, hyperkalemia, shock-like picture or dehydration-like picture in the patient, right? So this is a female with salt wasting crisis. And third thing, they have mentioned that she is also having ambiguous genitalia, right? So if there is a female who's having CAH-like presentation with ambiguous genitalia, salt wasting crisis, hypoglycemia, you should suspect 21 hydroxylase deficiency. So the likely diagnosis in such a patient is 21 hydroxylase deficiency clinically. Another evidence is given that 17-hydroxyprogesterone is elevated. We know that elevated 17-hydroxyprogesterone is the screening test. So what is the likely diagnosis? 21 hydroxylase deficiency. That is how we have made the diagnosis. Okay. Now, any CAH patient, including 21 hydroxylase deficiency, you have to start the patient on hydrocortisone. What is the dose of hydrocortisone which is started? Generally, higher doses of hydrocortisone is needed in the patient. Let us have a quick review of how we do the management whenever a patient presents in crisis of CAH. So I'm going to discuss, I'm giving the heading management of CAH patient. The most common variety, I'm taking prototype 21 hydroxylase deficiency, who presents to you acutely. Whenever a patient presents to you acutely, the first thing to do is, because the patient will be presenting with shock, so you will try to do shock management in the patient. So in shock management, you will try to give normal saline boluses as you will give for any other shock. So normal saline boluses will be needed in the patient. And after shock management has been done, you will put the patient on IV fluids. And according to AIMS Protocol 2024, these patients should receive 1.5 times the normal maintenance. This is a very, very important point which you can add and highlight in your notes as well. So 1.5 times the normal maintenance is needed. Apart from that, second thing that you need to do is start steroids in the patient. Why? Because CAH is characterized by deficiency of glucocorticoids, generally as the patient is presented with hypoglycemia, plus there is also a salt wasting crisis. So what is the agent of choice you will be starting? Yes, the agent of choice in the patient will be hydrocortisone. Now the interesting thing about hydrocortisone is, if the examiner asks you, what is the maintenance dose of hydrocortisone? Your answer should be, sir or ma'am, 10 to 15 milligrams per meter square per hour. That is the general maintenance dose which is needed. However, majority of these patients, when they present with some sepsis or some acute trigger, some illness which has caused a crisis. Any patient, CAH patient who presents in crisis, the initial hydrocortisone dose is always 2 to 3 times. And many times, if there is inadequate response, transiently you may need to increase the dose as well. So whenever a patient is presenting to you, since the patient has presented to you in crisis, so you will be giving the higher dose. What is the higher dose you will be using? AIMS protocol as well as Nelson agree 2 to 3 times the higher dose, which is 50 to 100 milligrams per meter square body surface area per day. And it is not given as a single dose, it is given in 3 divided doses. Generally, doses what are not asked in super specialty exam. One exception is CAH patient where doses are asked. And this question is based upon a concept as well as the doses. That is why I am discussing it as a standalone MCQ. So 50 to 100 milligrams per meter square body surface area per day in 3 divided doses, that is every 8 hourly you can give it. Hydrocortisone, you will give it like this, you will give till 48 to 72 hours. And once symptoms are controlled, if hypoglycemia and the other symptoms, plus minus other symptoms, other parameters, whatever parameters you are following, they are controlled, then you will decrease the dose. You will decrease the dose to a maintenance dose of 10 to 15 milligrams per meter square per day. If you read Nelson 22nd edition, Nelson gives a range of 12 to 15. So 10 to 15, 12 to 15 is just a matter of expression. Basically, you reduce the dose by 1/3 of what you had originally started. This is regarding hydrocortisone. Now, what about fludrocortisone? In salt wasting crisis, remember that fludrocortisone is needed. However, if dose of hydrocort is equal to or more than 50 milligrams per meter square per day, there is no need to add fludrocortisone. Why? Because in this dose of hydrocortisone, it also has a strong mineralocorticoid action. And adding fludrocortisone can sometimes actually make the patient swing as a pendulum from one end of spectrum to the other end of spectrum. Right? Too much of rapid change in hemodynamics is always deleterious for the patient. So, if the dose of hydrocortisone is equal to more than 50 milligram per meter square per day, no need to add fludrocortisone. You will wait. Till what time? Till the dose is tapered down. Once the patient is stable. Then you will add fludrocortisone. So, once the dose of hydrocortisone hydrocortisone, I'm just writing like this, hydrocort is reduced, then you will add fludrocortisone. And what will be the adding dose? You will be starting at a lowest possible dose, 0.1 mg per kg per day. You can increase it up to 0.2 mg per kg per day also. Subsequent dose reduction, elevation will depend upon the patient, and some of these children not only require IV fluids and steroids, when you discharge them, they will also require sodium chloride supplementation, which is added to the feeds which are given to them. This is the management of CAH, particularly the crisis. I have edited out the unnecessary information, which you can always add in the theory paper. The aim is to understand the key points here. In super specialty exam, examiner, particularly INISS examiners, are not testing how much you know. They want to test whether you know the concept, the basic principle behind this or not. I'm quite sure most of you have read about the topic, but when you solve an MCQ like this, go back and read again, your perception changes and you start to see things which you never knew existed in the notes or in the protocols. So now go back to the question and see whether you can answer the question now or not. Now have a look at the question. So this is a girl child who has CAH, likely 21 hydroxylase deficiency, started on hydrocort. She was started on hydrocort at the high dose, appropriate dose, but there was no response, so dose was hiked. It was a clinical decision which was taken. If the patient is having a severe sepsis, sometimes you need to give a higher dose. Sometimes in my clinical setting, in my clinical experience, I have seen a dose of as high as 70 to 80 milligrams per meter square per day, which has been given. So what is true regarding fludrocortisone as add-on therapy? Let us look at options one by one. The easiest option to rule out, fludrocortisone avoided in female CAH patients. That is not the answer. Obviously, gender is not a contraindication, right? So C is not the answer. Fludrocortisone not needed at high dose of hydrocortisone is a correct statement. Fludrocortisone started at dose 0.1 mg per kg per day. It is started, but they are asking the dose was hiked. It is a hiked dose in this patient. So fludrocortisone will not be started at this dose initially because the dose is more than 50 milligram per meter square per hour in this patient. So this is again not the answer. And option number D, initial dose of hydrocortisone must be low to add fludrocortisone. Dose of hydrocortisone must be low to add fludrocortisone is true, but they are using the word initial here, and so this is also not the answer. Some years back, a shorter version of this question with options very similar to this were asked, and people were very confused. It's a very, very tricky and tough question which was asked. So people were saying ki sir, option A is also correct, that we have remembered that fludrocortisone is started at dose 0.1 mg per kg per day. Yes, it is true, but they are asking you about this patient. In this patient, they have not said the hydrocortisone has been hiked. What they are asking you is hydrocortisone, they started at 50, they have now increased the dose. What is your opinion on fludrocortisone? So your opinion will be fludrocortisone is not needed at high dose of hydrocortisone. That is option number B is the correct answer. About option number A, fludrocortisone, yes, it is started at 0.1 mg per kg per day, but it will not be started as an add-on therapy yet in the patient till you taper hydrocortisone. That is why option number A is not correct. Option number C is absolutely wrong, so this is not to be discussed at all. And option number D, initial dose of hydrocortisone must be high, not low. Normally, you start with hormones or you start with anti-epileptics, start with low dose and hike them. On the other hand, there are some conditions, for example, ACTH when you give in a patient of West syndrome, you start with high dose, and then if the response is there, you can taper it down. Similarly, in a patient of CAH, it's a controversial thing by the way, but in a CAH patient, you always start with high dose, no response, go even higher, but once response comes, then you taper and bring to maintenance dose, and that is why option number D is also not correct. Option number B is the correct answer. Would a similar question be asked? Probably not. But the key points to remember in CAH patient is, number 1, making the diagnosis correctly. Number 2, if it is a salt wasting crisis, which is usually the case because salt wasting crisis related CAH is more important, manage shock, start hydrocort. When you start hydrocort, high dose you start. What is high dose? 50 to 100. When you start high dose, need to add fludrocortisone is not there. But once the patient is stable and you taper, then you need to add fludrocortisone. And what will be the dose when you taper it? Later on, that will be 0.1 to 0.2 mg per kg per day. 5 or 6 points. Add them to your notes. Detailed discussion, you can refer to the video on disorders of sexual development that I have recorded fresh in the new upcoming version on PrepLadder Super Specialty. More such questions, more such tricky things we will be taking in the detailed videos. Yes, they are tricky. Easier thing for me is to avoid it. But when you sit in the exam, every MCQ will matter. It is a controversial question, very controversial when it came. That is why I took it up. I hope you understand the gist of it. Thank you so much.